and talk in detail about how we can take it further.
Hello, sir. How are you?
Good evening, Dr. Satur.
Uh,
Good evening, Dr. Chavla.
Gurmani, good
Good
evening.
evening. Good evening, sir.
Good evening, everyone.
And
Panda sahab.
लोहानी सर नमस्कार
namaste, namaste. Dr. Vitul Gupta, good evening.
Good evening, sir. Good evening.
वितुल सर
भिरमानी
नमस्कार
Namaskar.
हाँ नमस्ते. कैसे हैं भिरमानी बॉस?
एंड शतुर सर नमस्कार
नमस्कार नमस्कार।
ये तो सारे को देख के मेरे को कॉर्डेलिया जैसे लग रहा है कॉर्डेलिया का फीलिंग आ गया तो पूरा सीसीडीएसआई फैमिली को देख के और कॉन्ग्रेचुलेशन डॉक्टर लोहानी फॉर द सीएमई कोऑर्डिनेशन एंड वेरी नाइस टॉपिक्स। ये जो डॉक्टर शतुर का टॉपिक जो सार्कोपिनिया ये रियल भल्कानो है और कमलदीप का तो वेरी रिलेवेंट टॉपिक। आई नो
दोनों टॉपिक काफी सोच समझकर सेलेक्ट किया गया है आज के लिए।
नहीं बहुत 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 पर्टिनेंट है प्रेजेंट सिनेरियो को और सारे को इसमें अपडेट होना चाहिए। बहुत अच्छा किए हैं। तो बाकी प्रेसिडेंट सर हमारा ज्वाइन किए नहीं?
अभी तक तो नहीं दिखे।
हाँ
अभिषेक
भिरमानी सर अभिषेक फोन करो मधुकर सर को, राय सर को, मधुकर सर को फोन करो।
वीरमणि सब क्लिनिक में बैठे हैं क्या अभी?
हाँ, बैठ गए आके हम लोग। मेरा डेस्कटॉप यही है ना।
अच्छा वो पूरा
आप
क्लिनिक वाला माहौल आ रहा है सर, इसीलिए
अभी
पूछे।
जस्ट तो हम लौटे हैं कोचिंग से।
ओके।
नहीं आप लोग भिरमानी सर को देख रहे हैं, भिरमानी सर के सामने जो बैठे हैं आप देख नहीं पा रहे हैं।
वीरमणि सर सर यू आर म्यूट।
डॉक्टर गुरुराज, यू आर म्यूटेड। डॉक्टर गुरुराज, यू आर म्यूटेड।
या कई
नमस्कार सर।
बार जो नजदीक है वो दिखाई नहीं देते।
ये जो स्क्रीन है हमारा जो जूम का वेबिनार का, ये इससे टाइप है जो आप जिनको देख रहे हैं उनको सामने कौन है आप देख नहीं पा रहे।
सर नमस्कार राय सर।
प्रणाम सर।
सर
राय सर।
प्रणाम सर।
Pranam,
राय
pranam,
सर
pranam.
प्रणाम।
Everybody, good evening to everybody.
नमस्कार सर।
टचिंग योर
नमस्कार,
फीट सर, चरण
सर
स्पर्श।
डॉक्टर राय, गुड इवनिंग।
Good
Good
evening.
evening, sir.
गुड इवनिंग।
प्रणाम सर, सबको प्रणाम।
हमारे सभी stalwart, I'm glad everybody is here.
सर
Sir, how can we miss such an important, CCDSI meeting?
Thank you,
Yeah.
thank you.
and the topics are so relevant, even
Yes.
we need update on these topics very much. So ये
Yes.
हाँ ये बहुत टाइमली है और पर्टिनेंट है। इश्यूज आर वेरी बर्निंग एंड स्पीकर्स आर सो गुड।
And both
Dr.
these speakers
Shatur.
are excellent.
Yeah, Dr. Shatur and Dr. Chawla.
Both are
So-
excellent speakers.
Both are excellent speakers. Yes. And as Dr. Panda has said, the topic is relevant for today.
Yeah, very relevant. Sir.
सॉरी।
बहुत दिन से इस टॉपिक को चेस कर रहे थे डॉक्टर सत्तूर। फाइनली ही गिव हिज कंसेंट सार्कोपिनिया पे। करीब करीब हम लोग 4 महीना से कोशिश कर रहे थे।
This topic is very close to my heart. So, and we are doing some trials also on the dynamometer.
Dr. Rai, sir, I am sending tomorrow 15 membership forms.
Oh, good.
Very
Good.
good.
Thank you, thank you.
Secretariat. So we will be in a process to form the Punjab chapter.
Good,
Whenever
good.
the forms are accepted.
Oh, very nice.
Yes, it will be accepted. If it is,
ग्रेट
I think it
ग्रेट।
will.
So we will have
It must contain.
30
It must be
more than
containing all
30
the relevant
members.
information.
हम कुछ फेलोज का भेज रहे हैं
हाँ
सर।
फेलोज का आपका उड़ीसा से नहीं आया, हर जगह से आ रहा है, आपका उड़ीसा और राजस्थान का 2 जगह से नहीं आया है।
हमारा 4 फेलो अप्लाई करने के लिए तैयार है अभी।
हाँ तो उनको ये कर दीजिए, द डेट हैज बीन एक्सटेंडेड अप टू 30th जून।
सर मैं मई में कर दूंगा सर, कल परसों तक कर
करवा दें।
सर।
वही आज हमारी बात हो रही थी कि उड़ीसा से नहीं आया, डॉक्टर पंडा बोले थे कि हम हमारे यहाँ से कुछ आएंगे।
सर नहीं, वो उनसे बात हो गया, वो पूरा तैयार कर लिए हैं, वो कल भेजेंगे सर।
विजित
और
प्रेसिडेंट आए
हम लोग
हैं
तो
डॉक्टर।
हम लोग डॉक्टर पंडा आपके यहाँ 20 तारीख को तो मीट कर रहे हैं, 20 जुलाई को। आई वो
हाँ नहीं, 19 सर, 20 2 दिन का है सर।
20-21 में है, 19-20 है। अच्छा 19-20 है, ठीक है, 19-20।
19th and 20th।
हाँ सैटरडे संडे। हाँ
हाँ आपको भेज रहे हैं, वो फ्लायर बनाया दिया, वो होटल का थोड़ा एडवांस करके ब्लॉक करके फिर भेज रहा हूँ।
थैंक यू। और आई होप कि हमारा जो रजिस्ट्रेशन हो जाएगा, जो जो हम लोग जिसके लिए स्पेशली इतना इंतजार कर रहे हैं।
ICCMD का रजिस्ट्रेशन सर हो जाएगा।
गुड गुड, तब हमारा फेलोशिप का वैल्यू बढ़ जाएगा। थैंक यू।
मैं उधर जो हमारा लक्षद्वीप प्रोग्राम से रिटर्न करने के बाद फिर एक राउंड पूरा फॉलो अप कर लिया ये। ऑल आर इन प्लेस सर, वो टाइम ही करेंगे उधर।
तो हम लोग अपना टिकट बुक कर लेते हैं।
हाँ सर, वो 19th 20th।
हाँ
19th
ठीक, थैंक यू।
तो ये दीपंजन सर को फोन करो।
गुड
अभिषेक।
इवनिंग सर। गुड इवनिंग सर, अभिषेक हियर, सबको प्रणाम।
हाँ अभिषेक
दीपांजन सर, दीपांजन सर थोड़ा लेट ज्वाइन कर सकते हैं,
अच्छा,
तो अगर लोहानी सर परमिट करें तो वी कैन स्टार्ट सर।
हाँ आई थिंक
मृत्युंजय।
वी हैव गॉट टू स्पीकर, शुड स्टार्ट।
मृत्युंजय सर।
मृत्युंजय उनका पर्सनल कोई फैमिली वो प्रॉब्लम, फैमिली।
रंजीत प्रेसिडेंट आए हैं,
नहीं मृत्युंजय नहीं
प्रेसिडेंट
आए।
ज्वाइन किए हैं।
प्रेसिडेंट को थोड़ा फोन करो।
उनको फैमिली इंगेजमेंट है, पर्सनल फैमिली इंगेजमेंट है। तो हमको फोन किया, अभिषेक को भी फोन किया कि हमको जरा सा आप लोग छोड़ दें। अभिषेक आपको फोन किए थे?
जी सर, मेरी बात हो गई थी।
हाँ तो हमको उनका कहा कि हमारा पर्सनल फैमिली इंगेजमेंट है कोई।
हाँ, जहाँ पे है वहां से ज्वाइन करना मुश्किल है थोड़ा।
मधुकर सर।
हाँ उनको
सर सब बात
he should join।
अब आप फोन किए अभिषेक सर, मधुकर सर को मैं बताता हूँ।
तो शुड वी स्टार्ट?
Yeah, I think we can start now.
प्रेसिडेंट सर को एक बार बुला लेते हैं सर।
हाँ, एक बार
देखिए।
प्रेसिडेंट साहब देखिए फ्री है कि नहीं।
आप देख लिए डॉक्टर पंडा, एक बार देख लिए, ट्राई करिए, नहीं तो विल स्टार्ट।
हाँ
अभिषेक एक बार डॉक्टर पारिक को भी फोन लगा दो।
नंबर बिजी बोल रहा है सर, मैं कोशिश कर रहा हूँ, तो तब तक हम शुरू कर सकते हैं।
सर, मधुकर सर से बात नहीं हो पा रही है अभी।
रिंग हो रहा है। He's not picking up, so we can start.
Okay. Good evening, everybody. Am I audible?
Yes, you are audible, Dr. Lohani.
Yeah.
So we are
On
live.
behalf of
We are live.
On behalf of Clinical Cardio-Diabetic Society of India, I welcome you all in our monthly CME program. And as you all know, every month we organize a CME virtually. At the outset, I would like to confess that I'm running fever and I may not be able to speak too much. But then I would like to admit that today's CME is very, very unique CME and very, very special CME, because the topic we have decided to discuss are of immense clinical importance, though less discussed. The first speaker is Dr. Sattur from Hubli. He will be discussing sarcopenia in diabetes. And the chairperson for the first session will be Dr. Jayant Panda. The second speaker is Dr. Kamaldeep Chavla from Vadodara, and he will be discussing genetic testing in lifestyle diseases. A very unusual topic, but very, very interesting topic. We all know Dr. Chavla belongs to Vadodara, and the chairperson for the second session is Dr. Dipanjan from Siliguri. Well, our CME coordinator, Dr. Abhishek, will introduce the speaker and chairperson in detail. But before that, there is a very, very important item on our agenda, that is blessings from our founder president, Dr. Professor A.N. Rai, and I request him to bless us with his valuable words and declare this CME open.
Thank you, Dr. Lohani, Chairman Scientific Committee. On behalf of CCDSI, I welcome my Dean, Dr. A.K. Birmani, past President Dr. Jayant Panda, learned speaker Dr. Sattur and Dr. Chawla, and Chairperson Dr. Dipanjan, and Dr. Panda and Dr. Dipanjan, and all other delegates. We are going to have very vital topics for today's discussion. They are the rare topic, but we will. I'm sure we will all be benefited. And I must thank Dr. Lohani for keeping this topic. Actually, these topics are rare, but they are very important. Sarcopenia especially is very important. So we are going to hear from Professor Dr. Sattur about sarcopenia. With these few words, I once again thanks everybody who has joined this program. Thank you.
Thank you, sir. Your kind words has always been very encouraging for all of us. And now I request Dr. Abhishek for Saraswati Vandana. Abhishek, is it possible to play Saraswati Vandana?
Yes, sir, possible. Anand ji, please proceed.
श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्।
Thank you, Abhishek. And now I request Dr. Abhishek, who happens to be the coordinator of the CME, to introduce our speakers and chairpersons. And then I will request our first chairperson, Dr. Jayant Panda, to introduce the topic and invite the learned speaker, Dr. Sattur. So Abhishek, please introduce the speakers and the chairperson.
Thank you, sir. It is my privilege to introduce the doyens and lions of medicine in this country. For chairperson, we have got Professor Jayanta Kumar Panda, sir. Sir is known to all of you, all of us, in fact. Sir is the professor of medicine and in fact HOD of Medicine in Cuttack Medical College. Sir has been our president for our society. Sir was our dean also. Sir is a senior member of API, RSSDI. Sir has held many position, innumerable position, and very kind to all of us. He is one of the pillar of CCDSI. The second chairperson is Dr. Dipanjan Bandyopadhyay. Sir is professor of medicine from Siliguri. Sir is our editor-in-chief for the upcoming Journal of ICCMD. Dr. Dipanjan will join in next few minutes. He has been traveling somewhere. For speakers, Dr. Gururaj B. Sattur. Sir is a renowned cardiologist of world fame and lifestyle expert. Sir has a very greater found for this society. Personally, for myself, Sir is very kind to me. Sir has delivered more than 700 lectures across the world on lifestyle disorders and the metabolic diseases. Sir is a member and important member of our society. He is from Hubli and he has got many accreditation in his sleeve, including holding important post in Indian Lipid Society of India, RSSDI, API at the state and the national level all. So I welcome you, sir. Again, I welcome our next speaker, Dr. Kamaldeep Chawla from Vadodara. He has been associated with our society since long. He is one of the important member of Gujarat chapter of CCDSI. He has been a founding member of IDCME. We all are associated with this society. Sir is DNB cardiology with many fellowships, and he is a very good metabolic work on metabolic disorders. So at the outset, I will welcome all of you, sir, both our chairpersons, sir, Professor Panda and Professor Dipanjan Bandyopadhyay, and I also welcome our renowned speaker, Dr. Gururaj B. Sattur, sir, and Dr. Kamaldeep Chawla, sir. Now, I will request the first chairperson, Professor Dr. Jayanta Panda, sir, to welcome our first speaker and start the CME.
Thank you, Abhishek. It's a pleasure again with CCDSI family, and always CCDSI thinks different. That is evident from this webinar agenda. My most revered, my mentor, Professor Ian Raisher, and our president, sir, will be joining. My friend, philosopher, guide, Dr. A.K. Bhirmani, the dynamic administrator, academician, who has taken all of us very closely in the CCDSI family, and Dr. Lohani, who has thought differentially this program, and then Mrityunjay sir and Abhishek and then Dipanjan, all are family members. Very innovative CME, and without much delay, I'll call Dr. GB Shatur. And as I know, sir, he is a very committed member in all physician association, especially in the field of hypertension. I've listened, sir, in the Hypertension Society and also World Congress, and also in American College of Physician program. Dr. Shatur has visited us, and also Lipid Association program. We have listened his very important deliberations. And sarcopenia is an issue which almost all of us the face. Not only we knew it little late, but it's a very common thing in metabolic disorders. and you will be surprised by the time you become 40, you start losing muscles. By the time you're 40, you're losing muscles, and by the time you are 60 or 80, the muscle mass, the lean body mass is much wasted, directly related to insulin resistance and the diabetic complications. So the very important topic is taken today, the sarcopenia in diabetes, an unrealized volcano by Dr. G.B. Shatur, and he'll be telling us regarding the issue, and the end will be taking up questions. I also invite Dr. Vitul Gupta and many other faculties who have joined us, and all the attendees for this important session. And Dr. Shatur, the podium is yours. Please share your screen and start presentation.
Is that, can everybody see this, please?
Yeah. This is visible, sir. Please, yeah. Visible and full screen, and you are audible.
Thank
Please
you.
go ahead.
Thank you, sir. And good evening to all. It's so nice to see all the friends of the physical touch on this evening. It's raining in Hubli, Karnataka. I hope probably it's raining somewhere else too. And without wasting much time and thanking all the members who have attended this, sarcopenia, an unrealized volcano, is the name I gave for this title almost around a decade ago, because we invariably miss sarcopenia. We just keep on asking in the OPD, why have you lost weight? He hasn't lost weight. His muscles have wasted. His muscles have wasted because he is not aware of the proper functioning, proper taking care of the muscles. And we are all guilty partially in this regard, because in our busyness, we normally don't teach them strengthening the upper limb muscles, strengthening lower limb muscles. So with that, sarcopenia, although it begins around 30 years of age. Why? Because in any conference I see the girls, the boys, all doing post-graduation, younger lot, going by a lift, even to the first floor, which is a shame. I still walk up to third floor. I don't expect everyone to walk, but it's very important for younger generation to realize, because 62% of Indians are young adults. No question of taking lift to the first floor. It's very important that this culture has to really up. Okay, people like this who are injured, lift is meant for them and not for normal people. Prevalence of sarcopenia, sort of rough guide. India, of course, hasn't produced many papers. There's one paper which we'll be seeing as I go across. USA has done a lot of studies on this. And as we already said, sarcopenia, although it begins around the age of 30, 35, it peaks after the 60 years of age. 13% of people 60 or older, 11 to 50% over 80 years of age. But rather, I would take it under the Indian circumstances, up to 40% of people aged 60 and over have got significant sarcopenia. And sarcopenia is defined as a progressive and generalized loss of skeletal muscle mass and strength, and it's strictly correlated with physical disability, poor quality of life, in fact, going on to death with other multisystemic issues. Now, you may be thinking that the sarcopenia has been going on for hundreds of years and known even during the Second World War, where soldiers were made to rest and lost the muscle. But it is only Rosenberg in 1989 that proposed the term sarcopenia. Now, we know that muscle is not just for the body movement, the strength, the postural balance, but it has an endocrine function. It's the main protein storage, glutamine synthesis and storage, and glucose level homeostasis. Sarcopenia clinical guidelines, many have come up with their own, including the European consensus. But This is one of the latest sort of reviews I could get. Sarcopenia, no consensus, no diagnostic criteria, and no approved indication. How did we get there? But nevertheless, we need not be that pessimistic over this. Now, just we can go through this here. What are the reasons for this? Several potential reasons why there is no specific diagnostic criteria. One, lack of method to measure muscle mass in large cohort studies to present. Lack of consistency or agreement, as I said, for definition of sarcopenia. No systemic measurement of the functional status. Now you can see a sarcopenia has huge risk factors. Obesity is number one. We not only have thin fat Indians, but you can see that younger generation is overall obese too. Old age, mitochondrial dysfunction, certain comorbid conditions like diabetes, respiratory illness. Then inadequate diet, inactivity is not just inadequate diet. I would also add the word improper diet. And of course, we all know that ultimately inflammation has a tremendous role. And now, inflammation, insulin resistance, as we know, we talk of this right from the gut microbiota to Alzheimer's disease. Risk factors, we all know this: age, gender, physical inactivity, diabetes, malnutrition, and smoking. Now, what are the impacts of sarcopenia? Poor overall disease progression, free survival rate, post-op complications, especially where you make them lie down. That is one of the reasons why top surgeons, even after surgeries like on a brain surgery or on a spine surgery, make them walk on the very second day. So it is very important to realize post-operative complications worsen as you make them lie down a longer time. And of course, falls, fractures, they are all part of sarcopenia. Cognitive impairment is a recent addition. I have not been able to find any literature as to how could sarcopenia affect cognitive impairment, because cognition needs to be aware, to be in the present. Maybe patients with sarcopenia will not do that. Other symptoms like slow walking speed and difficulty carrying heavy items. And this is an important slide. When the lean body mass goes on becoming like this, look at here, at 10% loss, you just decrease the immunity, increase the risk of infection. Come down to 40% of the lean body mass, increase the risk of death from pneumonia. And as you go, like in 30%, difficulty sitting, pressure ulcers, pneumonia, and inability to heal. And fall is the greatest enemy of sarcopenia. So you are walking around, legs are not strong, you don't do lower limb exercise, you naturally fall with a brain injury, spine injury, fracture femur is very common, and you get admitted to the hospital. Now, comparison, there are a lot of comparisons, like say, European Society also did its own work, and it refined its own work too. The slide just takeaway point would be, as you age, and you know that for Indians, the average survival rate now used to be around 64. Now it is 72.4 years for an average Indian. So you can see the long way we have come to be fit. Now, what are the factors that influence? As I already said, lack of exercise, lack of protein, nutrition, and we mainly have carbohydrate, as we know, as a main diet. And change in the function of the endocrine system, oxidative stress, mitochondrial dysfunction, denervation of the skeletal muscle as you age, and then abnormal skeletal muscle repair, gut microbe dysbiosis. I already told you how gut microbe dysbiosis is gaining tremendous importance. So these are all important things to realize. And this is just beat sarcopenia. You can do it. What you do in the early years of life, prevent and delay sarcopenia, maximize muscle in youth and young adulthood. Make them join gym, make them go for a walk. They don't like going for a walk because people think he's an old guy, but they can keep running. Running, definitely. There was a concept running would hurt your knee joints, but there are some studies that have proven that regularized proper running will not affect the joints. And so maximize, maintain in adulthood, and reduce the loss to minimum in older age. Of course, all can't have six abs like Shah Rukh Khan, but I see no point why many of us can't have the 90 centimeter abdomen and 80 centimeter in women. But unfortunately, most of us see in the FTV rather than on or any catwalk, which is not there in practical. Just to prove how sarcopenia can be devastating, look at this wrestler at age 63, absolutely well muscled. The same guy continues exercising at age 79. Look at the amount of the pectoral tissue lost. Look at the amount of deltoid lost. Meaning, even if you exercise, like death is an ultimate thing, sarcopenia also appears to worsen as we age. Now, how do you go about? I mean, how do you know that a guy has got a sarcopenia? This is one of the rough ways of going ahead. Look at 5 dominant symptoms that is called as SARC-F: strength, ambulation, rising from the chair, climbing, and falls. The total score is 10 points. Score of more than 4 is said to be specific. For example, in strength, maybe grip strength, there is some sort of energy. You take that to point, take that number 1 point for that. Assistance in walking, it needs only 1. So 1 plus 1, 2. Rising from the chair is very, very important. Dr. Anil Virmani remembers many times in almost all my talks on the stage, I make people stand up and sit, and also do some sort of semi-squatting position. Climbing stairs become difficult and falls become very common. What are the tests for sarcopenia? Gait speed test, chair stand test. That's for the lower body strength. And of course, the grip strength is overall muscle strength. Walking test, all of us can do this in the clinic. A straight, flat path of 4 meters is marked. Individual is asked to walk at their usual pace from one end to the other. I am taken to walk, the 4 meters is recorded. Assessment: if the walking speed is less than 0.8 meters per second, it may indicate severe sarcopenia. I'd please like you to go through this slide once again. And very important that you make this in your clinics too, that impresses the patient. That you are really caring not just for his diabetes or hypertension or bronchial asthma, but you're taking care of his muscle mass too. This is a chair test. You sort of cross your arms, sit up, sit down, sit up, sit down. Around the age of 60, you should be doing at least around 14 goes in this, 14 to 18 goes in this. And hand grip is an excellent way of going through the sarcopenia. Hand grip, the Jammer dynamometer is a standard instrument. I've already got this Jammer dynamometer, costs around 1 lakh. And we have started doing some studies. Hopefully in the next program of ours, after 6 months, I should be able to give you some data. You can see here on this dynamometer, these are the ones provided by the dynamometer company itself. Just have a look there. Between the ages 60 to 64, it is in pounds. The normal is around 66 lbs, while in women, it is 37 to 68. You can imagine women, to prevent loss of muscles, especially post-menopausal, when a woman is no more a woman, harmonically, one should really do more efforts on the side of women. Hand grip strength, this is one of the Indian studies. Go through the last part. Mean age 44 years, cut-off male less than 27.5 kilos, and for females, it is less than 80 kilos. But don't underestimate women's strength in general. Their physical strength could be lower, but the mental strength is terrific, and we all men have experienced, married or not. Sarcopenia is considered as primary when no other specific cause is there, and it is considered as secondary when you, of course, have some causal factors. Physical inactivity is the most important contributing factor to sarcopenia, and also the lack of energy, mainly the protein energy. Of course, less than 6 months, we call it as acute. More than 6 months, we call it as chronic sarcopenia. Sarcopenic obesity is becoming extremely common throughout the world. It only means you have abnormal excessive fat which replaces the real muscle, lean muscle mass, and you tend to, you look very sort of chubby, but that chubbiness is mainly because of excessive fat in all unwanted places. What does it do? Strong negative clinical impact may lead to, again, disability that you already saw. Malnutrition also needs, as we know, and many diabetics, when they have malnutrition, naturally 1 plus 1 easily becomes 2 or even 3 and makes it worse. Now we just talk a few words about diabetes-induced sarcopenia. Evidences suggest that insulin resistance is associated with impaired skeletal muscle glucose uptake and utilization and intracellular accumulation of TG fatty acids. They are associated with sarcopenia. I already made a point that insulin resistance has a role to play, especially in Indians. That's why many experts say it is not that 150 minutes of exercise per week for Indians. We are phenotypically, genotypically very different. It is 300 minutes of exercise per week, not 150, according to ADA or AHA. There is lipid accumulation in myocytes. So all in all, insulin resistance, hyperglycemia, and diabetes per se induce mitochondrial dysfunction, impaired oxidative metabolism. Now we come to some synopsis on the drugs, anti-diabetic drugs. Metformin, which is gold standard. If anyone wants to combine any of the remaining 14 class of anti-diabetic drugs, metformin is a gold standard. It's almost like an innocent bystander. Positive effects, potential benefits in preventing muscle loss, improves insulin sensitivity, reduces inflammation. What about the negative effects of metformin? We normally overlook. Some studies over long term suggest that it interferes with the muscle protein synthesis due to its impact on mitochondrial function. So I think it is very important to be aware, because metformin is almost, used extensively. But if the patient starts losing weight, becoming thinner, one need to think of metformin. Insulin, positive effects can prevent muscle wasting, promote an anabolic state, we all know, improving protein synthesis. If you must have heard, when you start a patient on insulin reluctantly, in many patients, from around 52, they become 58, 60. And that is a positive effect of insulin. Now, that can be devoid of much mass of fat if they are to do some exercise. Negative effects of insulin, over reliance on insulin can lead to weight gain, including fat mass, which might mask the underlying muscle loss. Sulfonylureas, positive effects, stimulate insulin secretion and can maintain muscle mass. Negative, hypoglycemia, even with drugs like glimepiride. If you tend, some people use even 6 milligram, 8 milligram of glimepiride. I normally stick to around 4 milligram. And you should remember that hypoglycemia is an extremely common side effect, especially when you combine with other drugs. Glitazones, especially we now use pioglitazone. Rosiglitazone has fallen into disrepute. Extremely important drug for India because it is affordable, improves insulin sensitivity, has anti-inflammatory effects. Negative, of course, it causes weight gain, primarily to increased fat mass. GLP-1 receptor agonists, which we are now using more and more, enhance insulin secretion, promote weight loss, fat mass reduction. Negative effects of GLP-1, limited evidence of the direct impact on muscle mass, and more research is needed. We all know that recently Monjaro has been introduced, which causes weight loss weight loss of around 15 to 20 kilos in somebody who is 100 kilos. But unfortunately, the weight comes back with a revenge when you stop it after 3 months. DPP-4, increase in creatine levels, no significant weight gain. That has been promoted mainly as something that does not increase your weight. Direct impact on muscle mass is not well established. SGLT2 inhibitors, now they're more a cardiac drug than a diabetic drug. Modest weight loss and improved glycemic control, potentially mitigating muscle degradation. Negative effects, there's a potential dehydration, as we know, which impacts muscle performance. Risk of muscle loss promotes fat loss, but also leads to decrease in the lean body mass. And this is very important. That is the reason why I heard many people, including Dr. Dr. Anil, Dr. Panda, discussing on the negative effects of SGLT2 inhibitors in some of the meetings. Should it be used in elderly people at all, these drugs? So that is open to discussion at the end of my talk. Now, what happens when you lean body mass you keep on losing? I initially already seen it. Around 10% you decrease immunity. When muscle loss goes to 40%, there is an increased risk of death. The worst is a fall. A banana leaf underneath your foot is just an excuse, but you are highly prone to fall, call an ambulance, get admitted. What about the feature of sarcopenia? Will we have a consensus on the definition? Will sarcopenia become widely recognized even in our clinics? Will the regulatory agencies come find some functional outcomes? Can pharmacological interventions be effective? So, potential therapies, physical activity is sine qua non in sarcopenia. What sort of physical activity? Not just the aerobic. People like to walk around 5 kilometers, but resistance exercise like doing the bands and lifting dumbbells, for example. And nutritional intervention, it is not just 1 gram protein per kg per day that we talk of. It is around 1.2 gram of protein per day. And unless the elderly people walk and do some sort of an activity, this excess protein may not be very good. Then, of course, vitamin D, long chain PUFA, and oxidants. Omega-3 fatty acids are my very favorite agents. I buy them from Amazon. I suggest, I request that all the members here should start, even those who are vegetarian, and no need to bother. They are in a small capsule form, work excellently. Your mood is almost always elevated, and many of the effects of omega-3 fatty acids have not really come out. An impact of high protein, we all know this, and approaches to augment skeletal muscle resistance training. This was one of the excellent papers by Dr. Peterson. And what does he say? Resistance training is an effective intervention for increasing muscle mass and strength in older people, normalizing blood pressure, improved insulin sensitivity, decreased abdominal fat, increased metabolic rate, prevention of bone loss, reduction of risk of falls, reduced pain, and improved physical function. Now you know the importance of resistance exercise. You can ask them to start with 1 kilo dumbbell, increase it to around 2 or 3 kilo dumbbells. They are easily available anywhere. This is very important. And of course, for the legs, one can do half sitting exercises, which are very good. And the second line you see there, 2 to 3-fold increase in muscle strength can be accomplished in a relatively short period of time in elderly people. I think that is an important take-home message. This is some of the elderly people doing the exercise. Of course, don't over-motivate them. This lady got over-motivated and tried climbing up a pole. Now, don't do this. She will have dislocation of the hip joint. And, as I already said, PUFA, fish oil are very good. I earnestly request those who don't take non-vegetarian, those who don't take fish, you could still enjoy taking the fish oil. Of course, vitamin D supplements, are very, very important. High dose testosterone has really fallen into disrepute because of some complications. This is a very busy slide, very complicated slide. Now here it shows that you target activated protein kinase, RAS, many of the signaling pathways. If you just look at the top left corner, target RAS system, which are the drugs? ACE inhibitors, AT1R antagonists, and MASR agonists. So these are all very important to realize. And as I always say, this is again my favorite slide. I have put it on more than 100 platforms. Exercise, exercise, exercise. If you ask me, well, can I preserve my muscles? Can I be still strong and healthy without exercising? Yes, you can. The next best alternative to exercise is get hospitalized by repeatedly falling or with cardiac disease, diabetes, and other problems. Sarcopenia in a nutshell, resistance exercise is prevented, high protein diet is important, and of course, aerobics always go with it. Before your patients start seeing the scans or your reports and diagnose themselves, let us all open our eyes and be in touch with the reality. Thanks a lot.
So, very nice presentation, Dr. Shatur. Actually, not only Dr. J.B. Shatur sir has told you about the pathophysiology and the basic mechanism, how the metabolic disorders are associated with sarcopenia. He has shown from real life examples how things are moving and also discussed the anti-diabetic drugs and sarcopenia and discussed mostly the lifestyle, which are very important day-to-day practice, inexpensive and most required to keep your muscle mass intact. So it's a complete presentation on the topic. Now it's open for discussion. We can have comments or questions on the topic before we go to the next topic.
So, Dr. Meena Chabra from Delhi.
Hello,
Can
Meena
I,
ma'am.
hello,
Yeah.
can I ask a question?
Tell
So, sir, I'm asking you that even in osteoporosis, do you think muscle sarcopenia is more important and people who recover after fractures more than DEXA scans need muscle strengthening? Are we, that means, are we over attributing osteoporosis rather than addressing sarcopenia?
I think an excellent question. Probably one slide should be added here. I thought of this quite a few times, but thanks for reminding me again. Sarcopenia, osteoporosis, they definitely go hand in hand. Osteoporosis in Indian population, especially post-menopausal women, where the hormones take away the protection they got, worsens faster. In fact, women suffer more from osteoporosis and fracture head of the femur, etc., than men. I think there's an important consideration. Osteoporosis prevention is not very easy. Drugs are not very effective, and sometimes you need to take them for a longer time.
Yeah, because both are in the degenerative process. Like muscles, they decrease in the mass, the bone also demineralizes. And then when you get one, I think we should look for other and try to correct both. And many lifestyles help us improving both the conditions.
That's why it's called as osteosarcopenia, like Dr. Panda puts it. That entity is osteosarcopenia.
Right. Thank you, sir. Thank you so much. Excellent talk. Thank you so much.
Thank you, Meena ma'am. And
Dr.
very
Panda,
important. Yeah, sir.
Can I make some comments, please?
Yeah, Dr. Virmani. Yeah.
First of all, Dr. Raj, excellent talk. There is no doubt about it. And you have covered the topic very nicely. I just wanted to make a couple of comments. One, when we talk of sarcopenia, we must also remember its friend virility, because virility is a broader concept and sarcopenia is limited to the muscles. And these two go almost hand in hand with the elderly population as we age. I will not say elderly, as we age. Now, virility unfortunately is not preventable. It's a part of the aging process. Whereas sarcopenia is preventable if we do what you have just talked about, maintaining the muscle strength right at the younger age group and middle age group, having a high protein diet and all. Having said that, now the three questions that arise are, should we be using GLP-1 receptor agonists in patients with sarcopenia or frailty? The problem of muscle loss by GLP-1 receptor agonist is a recognized phenomena. And there have been a lot of skeletons tumbling out of the cupboard where we have seen that patients have really lost the whole glamour of their face. Their face has become sarcopenic with GLP-1 RA, possibly because of unsupervised and without doctor's recommendation, they have been taking it. So this drug it has got is definitely better, good cardiorenal benefits, but then it must be taken in a supervised manner. And we must say, do not take it, please do not take it just to reduce weight unsupervised without a doctor's advice. Number two, coming to SGLT2 inhibitors, there was again a lot of confusion whether SGLT2 inhibitors should be used in sarcopenia and especially sarcopenic obesity. Now we have sufficient evidence to show that it not only reduces frailty, it improves the endothelial dysfunction. It basically improves the muscle strength and decreases frailty. So SGLT2 inhibitors, if you look at the risk-benefit ratio, the benefit is far more than the risk that it may cause fractures or falls, just like GLP-1 RA. Again, there's a new drug that is coming up, and a lot of work has gone on that by Eli Lilly.
Monzaro. Monzaro.
Which one?
Monzaro.
No. That is the tirzepatide. Now
Oh,
this
okay.
is Bromagramab.
Okay. Yeah.
Bromagramab is basically a monoclonal antibody acting on the activin receptors, and it has shown to increase muscle strength as well as muscle mass. So that is one drug that we are looking forward in the treatment of sarcopenia once it comes.
Thank you.
Yeah. Very nice update, Dr. Virmani. You have added to the presentation and science and ensured Dr. Shatur's query regarding the inhibitors as well. If there are no other questions, we can move to the second speaker because it's time.
Has Dipanjan joined?
Dr. Dipanjan
Can I, Dr. Jayant, make one final statement after excellent Anil's, overall.
We'll do it at the end, sir. At the end of the other presentation, finally we'll take opinion and we'll wrap up.
Hey, let him make his comments right now because this is maybe in relevance to what I have said.
Yeah, I think what he sort of indirectly means is sarcopenia may start at 35, sort of improvise exercise in them, but in elderly, management of sarcopenia is more tailor-made than ready-made. I think that's really a take-home message probably of Anil's
Need to
statement.
individualize how to treat these patients.
Yeah.
So thank you. Thank you,
Yes.
Dr. G.V. Shatur, sir. And it's a very burning topic. I request others who are here can type their question also. Those who are watching, and also you can unmute and ask. We'll take rest of the questions at the end of the session because we have a very interesting topic by Dr. Kamaldeep Chawla and Dr. Dipanjan Bandyopadhyay sir here.
No, I think you can continue. Yes.
Sir, probably sir has not joined.
I can take up
We request Dr. Vipul Gupta to chair the session along with Dr. Panda.
Dr. Gupta.
Dr. Vipul Gupta.
And Dr. Panda, sir, both.
Before Dr. Gupta gives his comment, I'll tell Kamaldeep is a very innovative scientist, and along with the cardiology practice, he keeps his mind open for innovative things in the beautiful land of Vadodara. I have attended his program, and he has come to Odisha, and I have seen his inquisitiveness, and the man who found his genetic structure first before advising it to anyone. And I am tempted to get my genetic study with him after discussing his beautiful project. And you all will be liking his presentation, the genetic testing for cardiovascular health, insights into heart disease, diabetes, and lifestyle diseases as well. And the challenge is cardiometabolic. That's what in CCDSI we stand for. And if we know gene and its role in making the problems in a patient, it will be helping us for the precision medicine. And we have to know what we can do and what we can't do. So this is a futuristic intervention and analysis, and I'm sure his presentation will attract you for working up of your patients for genetic testing for this cardiometabolic issues and lifestyle diseases. I request Dr. Vitul Gupta sir, our co-chair, to give his comment and start the session. Over to you, sir.
So I think you should start the session, Dr. Kamaldeep Chawla, because Dr. Panda has very elaborately expressed all the things. So please proceed with your unique topic, genetic testing for cardiovascular health. Thank you.
And good evening, sirs. Thanks for those kind words. At the outset, I would like to thank CCSI for giving me this platform to introduce the topic and my passion project, Gene Sutra, which is a startup for me. And I'm the founder of this brand called Gene Sutra. But I'll take you through the journey of genetic testing for cardiovascular health. We all know that genetics used to be very boring for all of us when we were studying biology, especially for our entrance exams. When yellow pea pod marries green pea pod and what is the offspring? I mean, it used to be hell lot of a nightmare remembering all those equations of genetics. But let me take you through this journey of genetic testing. So why this topic became very important recently because of the celebrity deaths and the young deaths which we encountered. So we started discussing that is genetics really behind all these things, though we knew that lifestyle disorders are there. So on one hand, we were discussing phenotype, but on the other hand, the back burner was the genotype, which we forget to discuss. And so very recently on 1st January itself this year, Times of India carried a headline that the bitter pill is that 20% of doctors are obese, 53% are diabetic, and 24% are hypertensive. I'll not go into the details of epidemiology of non-communicable disease, but yes, we all know that India is world's capital for diabetes. Obesity is increasing on a exponential type, and 60% of total deaths in the country are attributable to cardiovascular diseases. Cardiovascular diseases in India are not only premature in onset, but if you add the burden of stroke, which is responsible for 80% of this burden, and year on year, if you see the increase is linear and it's ongoing. Similarly, for diabetes, and despite being high incidence, we also have known that genetic predisposition plays a significant role, especially in families with a family history of type 2 diabetes. Similarly, sir, for obesity, we see across a very short span, 2015 to 2021, the occurrence in children, men and women across subgroups is almost on a doubling spree from just within a short period of 5 years. And we also know that despite sedentary lifestyles, dietary habits, genetic predisposition definitely plays an important role in obesity and its complications. So, sir, why genetic predisposition in the Indian population came to our forte all of a sudden? It's not all of a sudden, but we were all struggling when the Human Genome Project started under the guidance of United States of America in the early 90s. Then the Caucasian pool, the Southeast Asian pools were added to these human genome projects. And with the onset or with the propagation of artificial intelligence, we could snatch these genes from the pool very easily. And thereby, as you can see on the right side of the screen, diabetes, obesity, dyslipidemia, hypertension, smoking, and various other traditional risk factors, the genes are actually mapped. For example, familial hypercholesterolemia and elevated lipoprotein levels, both genetically influenced, and we now have specific genes known which are responsible, like LDLR gene. For CAD also, largely specific gene variants like NP21 region, which is strongly linked to coronary artery disease. So for an AI platform, it has become very easy to snatch these genes from the genetic testing material and give a report precisely in a very uh, elaborate manner and also in a timely manner, which was not possible previously. It used to take generations to sequence the sequences which were found. So very important data published in JAC in December 23 is they examined CVD occurrence 30 years before and 5 years after type 2 diabetes mellitus diagnosis in Denmark. Almost 127 odd type 2 diabetes patients, which were age and sex matched. And type 2 diabetes individuals had 2 to 3 times higher CVD prevalence versus controls up to 30 years before diagnosis. And the odds ratio for CVD increased closer to type 2 diabetes mellitus, almost 2.18 to 2.96. And after the diagnosis, type 2 diabetes individuals had a 2.2-fold higher 5-year CVD incidence versus controls. So what it means is that any individual 18 years or 20 years who is 30 years away from walking into a diabetes clinic has a 5 times higher fold of CVD prevalence even before he has walked into or he has got the phenotype for diabetes. And a young executive or a middle-aged executive, 45 years, 50 years of age, who has already walked into your diabetes clinic, and the risk remains 2.2-fold higher for 5 years CVD versus controls. So just having genes for diabetes is itself a risk factor for the future occurrence of coronary artery disease and its related prevalence and its complications. So what we normally tend to correlate is the key factors affecting the heart disease on genetic basis are congenital malformations like ASDs, Holt-Oram syndrome, familial hypertrophic cardiomyopathy, idiopathic dilated cardiomyopathy, cardiac arrhythmias, long QT syndromes, or idiopathic Brugada's, QT-related arrhythmias, myocardial infarction of early onset, heart failure, hypertension, especially essential hypertension, not relating the secondary causes of hypertension into this. Blood-related disorders like familial hypercholesterolemia, familial dyslipidemias, atherosclerosis, be it inflammatory disease and thrombotic disorders. So all genes have been known and have been mapped, and we can transfer the genetic result into a clinical result very early and in a very comprehensive way. So how does genetic testing, how can it transform healthcare in India? Definitely, it detects genetic predispositions even before the symptoms occur. Genetic insights help tailor medication choices and lifestyle adjustments for individuals with risk profiles. Family screening identifies the family members and enabling proactive care and early lifestyle interventions, increase adherence to treatment, and planning for future generations to be disease-free. So how a genetic reporting is done or how is it ordered? Like we normally have the habit of taking CBC, thyroid profile, lipid profile. So what are the parameters that we need to see on a genetic testing report, or what are the parameters offered by a genetic testing report? So the first parameter is a polygenic risk score, which evaluates multiple genetic variants to assess an individual's overall risk of cardiovascular disease, providing a cumulative genetic risk. Variant analysis is a comprehensive analysis of genetic mutations related to cardiovascular diseases, enabling early detection and personalized treatment plans. Pharmacogenomics identifies how genetic factors affect drug metabolism, helping to optimize medication choices for cardiovascular conditions based on genetic profiles. And nutrigenomics analyzes genetic influence on nutrient metabolism, dietary needs, allowing for personalized recommendations to support health and reduce cardiovascular risk. So these are the 4 parameters which we are currently working, and very soon we are going to add a sports panel to our profile, wherein we can make recommendations for sports activities. And I'm sure with today's insight, I can talk to the team, my technical team, and we can also include whether sarcopenia can be found on a genetic basis or not. So the technology that we use is next generation sequencing and whole exome sequences, which are the part of the testing protocols that we have employed. So coming to the details of each of the 4 pillars of the testing, the polygenic risk score, it isn't about identifying diseases, it's about assessing the risk. So fortunately or unfortunately, the genetic disease parameters don't fit into specificity and sensitivity per se for a test, but what they follow is a concept of biostatistics called area under the curve. So for example, for diabetes, if 60% of Indian population or Southeast Asian population is having those genetic risk factors compared to those 60% population, how would my genes or your genes or the testing patient's gene fit into those 60%, and how we can predict their risk of developing diabetes is assessed by polygenic risk score. So the detailed analysis or explanation is it personalized or provides personalized estimate by disease risk by analyzing multiple gene variants, calculating a risk score, which is very objective and not at all subjective, and comparing it to population averages. PRS can identify high risk individuals, and those having higher PRS may benefit from early interventions, inform personalized medicine, and enhance disease prevention. It is important to keep that PRS does not diagnose disease. So, for example, your diabetes will be diagnosed only by your FBS of 126 or your ADA guidelines. Similarly, obesity, whether you follow BMI or waist hip ratio, that will diagnose obesity. But PRS will add onto the risk assessment of that particular individual for which the phenotype is being considered. The limitations is that PRS is based on current genetic knowledge and may not capture all genetic factors contributing to the disease risk. It should be used in conjunction with clinical evaluation. So I want to show this beautiful slide, which was published in NEGM almost 2 or 3 years ago. So what it suggests is that when we add PRS to our clinical assessment tool, the predictability of the phenotype increases significantly. So across ischemic stroke in AF, ischemic stroke, atrial fibrillation independently, CAD, hypertension, type 2 diabetes, when we go on to add a PRS score to our clinical assessment tools, the predictability of the disease goes significantly. To show what we have discussed so far, luckily I could find a very good article again published in JACC Imaging in December 2024. So what it says that not having the phenotype, you don't have a 70%, 80% block. Maybe your angiography is not done. Maybe TMT is just false positive. And you do a genetic testing and your PRS is on the higher side, because genetics result never changes. It is for life. Whether you do it at age 18 or you do it at age 50, the report is going to be same because it is collected from the genetic material. So if you have a polygenic risk score, which is on the higher side, it translates into adds predictive value for plaque progression and plaque ruptures beyond conventional risk factors. Very important data which has come out. So the next pillar is gene variant analysis, or monogenic variants as we call them. So these identify single gene, single disease, usually which are known to run in families. So for example, Holt-Oram syndrome, or for example, hypertrophic cardiomyopathy gene. So one gene, one disease, and we can identify whether the progeny of this individual would have the phenotype later in life or not. So some monogenic disorders responsible for hypertension, monogenic disorders responsible for heart disease like familial hypercholesterolemia, hypertrophic cardiomyopathy, prolonged QT syndrome, atrial fibrillation, Marfan syndrome, Holt-Oram, dilated cardiomyopathy are known. So even for stroke, we can have specific disease demarcation like small vessel disease, CADASIL, large artery atherosclerosis for iron arteriopathies, large artery dissection diseases for Ehlers-Danlos or Marfan syndrome, disorders affecting both small and large arteries to be ruled out, homocystinuria, sickle, Fabry's, cardioembolism, prothrombotic disorders, and MELAS like mitochondrial disorders. So across the spectrum of clinical disorders, genetic testing is there to help you and your patients. So we also can do genetic testing for hypokinetic hearts like HFrEF, for hypertrophic cardiomyopathy, for HFpEF also for restrictive heart diseases, for ARVCs and phenocopies, and for thickened heart with diastolic dysfunction, which might be myocyte hypertrophy, may not fit into the typical hypertrophic or restrictive cardiomyopathy patterns. So for example, ATTRV attributable to ARV diseases or amyloid diseases, ApoA1, even non-genetic disorders can be identified by specific genetic material if we have specifically asked for it. So the monogenic or the gene variants is the pillar which will identify and help us for individual disease mitigations. Pharmacogenomics, sir, I would like to show you a report when I come to that part of the discussion. But as we know that certain times a particular drug does not work too well for certain individuals, or it does not have the effect And in cardiology, most important medications are warfarin and its related substitutes, statins and clopidogrel. So if we can find these resistances, it would be the pharmacogenomic study for specific cardiovascular medications. And same nutrigenomics, sir, it's genetic predisposition to cardiometabolic diseases, to develop personalized strategies for prevention and management, provide personalized dietary advice. It can potentially help with weight loss, though it may not be the magic bullet for doing so, but definitely it can guide the clinical nutritionist or the genetic counselors can be of help for your individuals to manage obesity. So, sir, it's a basic, we need 3 cc blood for single test. And for the whole package of 4 parts, we need 3 cc, 2 vials in EDTA bulk. And the turnaround time is 4 to 5 weeks. We are supporting free of cost blood collection from Pan India other than Jammu and Kashmir. And we also offer free genetic counseling to the individuals who have opted for the tests. So, sir, how to read your genetic report? I'll come to a typical Gene Sutra report, and this is my own report. The only history which I gave them was that I'm a known hypertension and I have a strong family history of cardiac issues in terms of IHD affecting father and grandfather. So, sir, the screening test involves cardiometabolic health, CAD, hypertension, atrial fibrillation, and dyslipidemias, hereditary cancers. So, we cannot diagnose lung cancers, but we can definitely help in 7 odd hereditary cancers: breast, colorectal, gastric, male breast, ovarian, prostate, mental health disorders, neurological disorders like Alzheimer's and Parkinson's, focus and energy, ADHD, insomnia, migraine, metabolic and dietary factors, type 2 diabetes, alcohol dependence, celiac disease, and miscellaneous screenings for rheumatoid arthritis, multiple sclerosis, and asthma. So the typical summary of my report came that I have a PRS high for obesity and population average for type 2 diabetes, colorectal cancer, and coronary artery disease. If we go to the details of the report, so I have a PRS of 0.97 for my obesity, which translates to an odd ratio of 1.7. So the data pool currently is, when I prepared it was 8,000, currently it's 11,000 Southeast Asian volunteers added to the data pool against which we get a PRS. So for diabetes, my PRS is minus 0.28. And for CAD, my PRS is minus 0.78, which translates to a hazard ratio of 0.77. So I, on a genetic basis, have 23% lesser chance of getting CAD as compared to the average Indian population. Keeping our previous slides in the data that we had, with my risk factors, with my obesity, had my PRS been above 1 on the positive side, it would have been imperative to start aspirin from day 1. So coming to the pharmacogenomics, we study almost 75 odd medications across cardiology, endocrinology, gastro, hemato, immuno, antibiotics, and all subgroup of medications. So, sir, the recommendations for me which came out, they have very different for each individual. So I have to avoid amitriptyline use, and even if warranted, consider a 50% reduction in the recommended starting dose. So for me, on a routine primaquine, rosuvastatin, those medications are good to go. And the surprise which came out is for voriconazole, I have to choose an alternative agent that is not dependent on CVP2, C19 metabolism as primary therapy. That means basically voriconazole won't work in me. And understanding the implications, this report my wife should have. Maybe in future, when this medication is to be used, she can tell the doctors that this medication won't work in my husband. Some monogenic variants on a familial basis, we have carriers for cardiomyopathy, hypertrophic and congenital, and atrial septal defect, and unrelated to phenotype, autosomal dominant deafness and thalassemia due to HB-LIPOR. So there's no phenotype as such in the family, but the carriers are going on, and some generation future will have to be aware of these disorders. So coming to the detailed nutrigenomics report. So the first part is regulation of eating. So I have very poor satiety genes. Emotional eating and snacking pattern is typical. I have fatty food preference and bitter taste perception. The genes are poor, means I am more attracted to eat fatty food. Sweet taste is okay for me. On macronutrient requirements, sir, my response to MUFA is typical, but saturated fats and polyunsaturated fats won't work or are not good to go for me. Proteins and carbs are okay. I also have very poor ability to maintain weight loss on a genetic basis. So coming to the intolerances, I have lactic intolerance, which is very poor, means I'm very sick. I cannot take paneer and all those things. Salt metabolism is poor, gluten intolerance is poor, and caffeine metabolism is typical for me. And then finally, the report goes on to add food allergies, skin allergies, and nasal allergies. So this is a typical nutrigenomics report, and very soon we'll be adding a sports panel to our nutrigenomics part. So, sir, after the discussion, naturally, the first question that comes is, so what are the indications of genetic testing? So, individuals with a family history of CAD or sudden cardiac death, individuals with unhealthy lifestyles such as smoking, alcohol, stressful lifestyle, all individuals with comorbidities like hypertension, diabetes, dyslipidemia, all individuals with recurrent diseases, and all individuals above the age of 18 years, and especially if want to enter competitive sports. So the future of medicine overall, as Jayan sir said, is precision medicine. Be it we'll be offering cell therapy, gene therapy, or recombinant proteins. But without a proper DNA test, we cannot offer a tailored therapy. And for precise execution of precision medicine, doing a genetic testing is very important. So is the audio audible?
You are audible.
Yeah, yes, you are audible.
Yeah.
The video is not audible.
And there is no sound.
I can do it for you, sir. I can do it for you, sir.
Yeah. Just increase the volume of your system.
हार्ट अटैक के ऊपर आज सुपर यंग एज में बिकॉज हमारी प्रोपेंसिटी ज्यादा है और अगर जो जिनको डायबिटीज है तो उनको डबल डेंजर हो जाता है आज के दिन में क्या हुआ है कि जस्ट टू एड्रेस इट आज के दिन में साइंस इस जगह पहुंची है जो बेसिक हार्ट अटैक की प्रमाण जो हमारे देश
So just give me a second.
हमारी प्रोपेंसिटी ज्यादा है और अगर जो जिनको डायबिटीज है तो उनको डबल डेंजर हो जाता है आज के दिन में क्या हुआ है कि जस्ट टू एड्रेस इट आज के दिन में साइंस इस जगह पहुंची है कि हम पूरी जीनोम सीक्वेंसिंग कर सकते हैं एक इंडिविजुअल की उसमें ऑलरेडी आइडेंटिफाइड 3 तरीके के जीन्स हैं एक है कार्डियक डिजीज का उससे पता लग जाता है कि किसको ज्यादा प्रोपेंसिटी है किसको नहीं है अपनी लाइफ को आप टेलर कर सकते हैं डायबिटीज का भी ऐसा ही है और थर्ड है कि कुछ कैंसर के जीन्स भी ऑलरेडी आइडेंटिफाई हो गए हैं तो आपको ये भी पता लग सकता है कि क्या प्रोपेंसिटी है क्योंकि अगर जो आप हम पहले कहते थे कि अगर जो आपके पेरेंट्स को हार्ट डिजीज है तो बच्चों को डबल चांस है अगर जो पेरेंट्स को डायबिटीज है तो बच्चों को डबल चांस है पर आप सारी जिंदगी यही सोचते रहो कि मेरे पेरेंट्स को था तो मुझे हार्ट अटैक होगा कि नहीं होगा आज उसके लिए 3 चीजों को मिला के हम एक प्रिस्क्रिप्शन लिख सकते हैं इंडिविजुअल के लिए जीनोम सीक्वेंसिंग Phenome is your body structure, your living habits, your stress levels, your where you live. जैसे pollution is a big factor in people's heart disease. उसके साथ और तीसरा हम जो डिजिटल मेजरमेंट करते हैं जैसे स्ट्रेस टेस्ट किया या एको किया या ऑल दोस थिंग्स ये तीनों को अगर जो हम एक एल्गोरिथम में डालते हैं ये ऑलरेडी हो रहा है देन वी कैन राइट horoscope of an individual.
So with that, I would like to end the academic discussion. And on a lighter note, the two gentlemen were trying to find Kamala Harris's genes, but they couldn't find any. Thank you.
Thank you, Kamaldeep.
I want to show one case. Can I show one case which is
quickly,
our case?
Quickly,
Yes,
you
sir.
can show the case.
Yes, sir. Yes, sir. Yes. So, sir, this is a young 45-year-old gentleman who came from Canada, Varma Chandrakant. He's my friend's brother, actually, sir. And he had myocardial infarction in Canada, and angioplasty was performed there almost 1.5 years ago. So naturally, because he came, he wanted whole body checkup, and we offered him gene testing. And so, to surprise, he got high PRS for colorectal cancer. And when we sent him the report, he told, yes, the mother died of colorectal cancer. So, sir, I mean, there will be many, many surprises when we discuss individual cases of genetic testing. Thank you, sir.
So it was a very enlightening presentation, and Dr. Kamaldeep Chawla not only discussed the indication of this genetic uh, testing to predict the cardiometabolic and lifestyle diseases, but he has shown his own report. What I was telling in introduction, he did his own report and has predicted his own conditions, and you'll also be tempted to do your own for such a informative analysis. And this is futuristic because not only we know our risk factors, we can try precision medicine. Now the session is open for discussion, and I request Dr. Vitul Gupta sir to give his comments and take questions.
Yeah, Dr. Kamaldeep, you have Kamaldeep, sorry. So you have elaborated a great, futuristic medicine, as Dr. Panda has already told you. So it is, I think it is for those who can afford it. Basically, India, most of the people are deprived section of the society where we cannot control even, anemia. So I think the purpose of CCDSI becomes larger, that those who can afford should go for genetic testing and risk factor profile. Those who cannot go for lifestyle modification, that is risk factor control, as the previous lecture by Dr. Satur also, exercise, diet, smoking, and alcohol. I think these are the four major risk factors we can predict that in future the person is going to have some metabolic disease, may not be cancer, because that is where the genetic testing comes and they can predict that thing. So if we can go for the spirit of CCDSI of prevention, so that focuses on lifestyle modification, that will again predict whether we are going for lifestyle modification, that will reduce our risk, may not eliminate the risk, but reduce the risk of cardiometabolic diseases. And if some person is not going for lifestyle modifications, he is bound to have some metabolic disease in future. So that is my take. Thank you very much for enlightening us for the future, what can be there if we are going to reduce the genetic testing cost, that will help population as such. Thank you.
What do you think is the cost of polygenic risk score? Because you made a point, not academic but financial. So what do you think is the cost? आपका क्या perspective है, क्या होगा?
मैंने कहा यार 10 पैसे की फर्सोलेट नहीं दे पा रहे हैं हम, 10 पैसे से कम थोड़ी होएगा ये.
ठीक है सर.
We cannot.
It's affordable, sir.
May I request Dr. Virmani for
Vitul
his
sir,
expert comment?
Vitul sir, I was inquiring about the price of the test, and it is not very expensive. Average patient who is affording the monthly cost of therapy 5 to 10,000 can easily go for that, because we are doing tests which include the imaging, biochemical analysis, and most of the patients are taking drugs from their pocket. So this is once in lifetime, the analysis, and not very expensive, I think. And Dr. Chawla will tell you the exact price, but this is say around 30 to
Many of
40,000.
times your diabetic patients, you continue giving metformin and metformin doesn't work for them. And just changing from metformin to SGLT2 inhibitor, the HbA1c melts like anything. So that is what precision medicine, and that's where genetic testing comes to help. Because metformin regulation in the body is also genetically mediated through the liver enzymes, which are genetically influenced. So, sir, there are many, many, many incidences. Like we had one patient from Hyderabad whose LDL wouldn't budge on anything. So then we did a testing and it came out she had LDLR gene mutation. And we just stopped statin, put her on PCSK9. She was affording, no doubt. It's not comparable to folic acid, but we put her on PCSK9 and sir, LDLs melted from 275 to 160. And that is 6 months ago, the latest reports we are waiting for. Sir. So definitely it's difficult to treat cases. We should be definitely using the
Thank you, Kamaldeep. Your views are well taken. Now listen to our Dean
Dr.
sir,
Virmani,
Dr. Virmani.
please.
Yeah, comment.
Dr. Virmani.
I have two comments to make. Number one, when we talk about genetic profiling, I think it's not a routine test. It has to have a particular special indications. When you're looking at monogenic diseases, like say monogenic diabetes or monogenic hypertension, you are hitting the bullseye. There is no doubt about it. It's a wonderful, you have to go for it because the whole treatment pattern changes. But when we're looking for polygenic diseases, I somehow am a bit skeptical about going for genetic profiling, not for any other reason, but basically when we are looking at clinical pointers of unhealthy lifestyle, I think we should be concentrating on clinical side more. And then lifestyle modification is not something that you recommend after looking at clinical pointers or after doing genetic profiling. It's a way of life. It has to be there right from childhood.
Yes.
What is important, and there's a wonderful article by Amit Khera, which was published way back in 2016 in New England Journal of Medicine. And I always quote that article. They did a wonderful study and they have shown that patients who had a very high genetic risk of coronary artery disease, in those patients by intensive lifestyle modification, the risk was reduced by 50%. So lifestyle modification means that basically environmental factors can modify the genetic profiling. So just to have a polygenic score, risk score, is just like, picking up a tarot card and saying this is likely going to happen. We don't know exactly what will happen unless it is monogenic. So
very well taken, sir. Very well taken.
Can I put a counter to just one point on this? So the gentleman who got TRS for his CAD but got to know about his cancer risk. Suppose you put him on a surveillance program, and if he's going to get cancer risk, he is caught early and prevented from metastasis. His life will be prolonged, sir.
That's true. See, that's why I'm saying when you're going for a risk profile by doing genetic profiling, you are basically looking to answer specific questions. As you very rightly said, whether this patient will improve with DPP-4 or with metformin, whether we should put him on this drug which is likely to cause cancer tomorrow. Suppose I put a patient, if I know this patient has a high risk of a medullary carcinoma thyroid, I'll never put him on a GLP-1 receptor agonist. So for these specific questions, maybe genetic profiling is excellent. There is no doubt about it. And I know you are offering it at very, very reasonable rates. Very reasonable rates.
Yes, sir.
The cost is not high, sir. And rightly you have told the indications. But my view is, if you have, you see, this is the era of technology, era of artificial intelligence, era of precision medicine. Here, if you have an additional information about the risks, sensitivity, and the genetic makeup, if patient efforts and everything goes right, many institution, many government will also like to include that in their battery. If it goes, then it's a additional information for the physician planning the treatment, planning the intervention. So that part has to be kept in mind. And thank you for the valuable opinion.
Dr. Panda, may I comment?
Yeah, sir.
Thank you for your opinion. I think I agree with you. And it is not recommended for everybody, but those who can afford, I think there is no harm in getting it done because you can, at least it can prevent cancer. That is very important. And those who are going to have heart attack and everything. So prevention, no doubt, lifestyle is going to help. But those who can afford, not for everybody, they should go. There is no harm in getting. And I will request Dr. Chawla to tell the members what is the average cost, because most of us are not aware.
A single pillar That is like whether you go for PRS or you go for pharmacogenomics or monogenic variant, or that is 15,000. That is the MRP, sir. We can definitely offer discount on that. And the whole package, if anybody goes, all four components, it is 48,000. It's already discounted. And that is also MRP. We can, for really wanting cases, we can give a discount. Because, sir, it's very important for us to do the tests right now and get a database of the clinical materials.
Yeah.
Thank you, Dr. Chawla. I think
Sir, I just want to add one more point that Gene Sutra is the country's first clinician-driven genetic testing platform. So please kindly support and whatever patients can be benefited with it, so we can help, sir. Please, sir.
And I request Dr. Chawla to offer a special rate for the members of CCDSI.
Definitely,
so
sir.
that,
Sir, Satur sir has a question, sir.
Yeah.
Yeah.
Just with the
Dr.
permission of
Satur.
Jain,
Yeah.
said to Kamaldeep, excellent talk, excellent work. What I want to know, in a premature coronary artery disease, I have got a couple of families, 40, 45 is the top age. They die, 5 to 6 in each family. Now, having diagnosed it, you just talked that aspirin could be the drug. Apart from aspirin, or all these people, the whole family, do you think start aspirin or do you have any other ideas?
Sir, I want to show one case. I mean, because of lack of time, I think I was not showing cases. But, sir, these are the real cases which we have done, sir. Just give me one more second. Is the screen seen, sir? Sir, is my screen seen?
Yes.
So just give me 1 second, sir.
Be quick.
Yes, sir,
9
just
o'clock
one
we'll
second,
wind
sir.
up.
Sir, 1 second, sir. Sir, so this gentleman is my patient, and he's my patient since almost 10 years. It's a bit long case, sir. And he has worked in Mirzapur series in season 2. And sir, he got a MI. He's just 50-year-old male right now. And he got an MI, and I did his angiography, and he underwent bypass surgery. But he wanted to understand because he had this type of family history with Sattur sir said. So, sir, he got obesity very high, CAD very high. Rest of the things were borderline or above average. Then, sir, he brought his 32-year-old sister, who is 18 years younger to him. She is Rajkumari Giri, asymptomatic, TMT negative. And, sir, we did her test also. So, she also got, sir, CAD risk, PRS very high, almost more than him. So, we opted for a CT angio because she was totally asymptomatic. And, sir, CT angio showed diffuse disease 40-50% in all the territories. So we have kept her on a very high statins, primary prevention along with aspirin, because her PRS is almost 4 point, it's positive 4.2 and her hazards ratio is almost 2.78, sir. So this is the family history and these are the type of patients, sir, whom we'll really help. This gentleman already got a MI. At least that sister we can prevent from getting an MI.
Okay.
Yeah, actually, as I told, as Professor N. Raishar commented, if the patient is affording, there is nothing wrong in having additional information which may help the physician to take a decision and help the patient to remain very careful regarding the predicted diseases, screen them early, detect them early, and treat them early. So with this, I'll invite questions to any of the speakers before we close, or else we'll take the take-home message of the speakers and hand it over to Lohani. So final round, anyone? Or else?
So basically, what I was talking is two
Bidul
aspects.
sir.
One is high risk, where the patient is affording. Definitely, these procedures should be indispensable. Like you are talking, like Dr. Satur has talked, that there is a family of people where young deaths are occurring. So where even if it is expensive, they should spend money to save lives. So that is, undisputed fact that once it is some type of diabetes where the person is going to live longer after genetic testing, that will be in fact cheaper than losing a life. So, but from the public health perspective, we are talking two perspectives. One is high risk, where it is indispensable or unrefutable evidence to go for these testing. Other is public health perspective. That was my take.
Well taken, sir. And the
Sir,
final
one
word from
question, sir. One question,
yeah,
sir. Sir,
yeah.
to Dr. Chawla, Dr. Jagdish here, sir. Sir,
Yes, sir.
namaskar.
Namaskar.
So I hope this also covers the like the nutrition part also, like specific supplements can be like prescribed according to the report, isn't it, sir?
Sir, so I will give you my own example. So, sir, what my mother was feeding me in childhood, we used to have cooked in cotton seed oil and groundnut oil. So she was doing justice to my genetics. And when my wife, she has come and we are affluent and she's using PUFA for all of us. She's trying to be more careful. PUFA is not going to work in me, sir. Polyunsaturated fatty acid on a genetic basis is not going to work. So my mother's wisdom is more important than the money that my wife is spending. And sir, it's very important. I
You are
did show
lucky.
one slide. Sir, I'm a very poor responder for vitamin D. So I have to take very regularly vitamin D supplements. Moment I stop them, I start getting leg cramps. So, all macro, micronutrients, everything is there as a part of the nutrigenomics profile.
So perfect. We'll not continue more longer.
Okay.
I'll request Dr. Shatur to give a final take home, and also Dr. Chawla to give a final take home before we hand over the session to Dr. Lohani and Dr. Abhishek to wind up.
Thank you, Jayant. It has been an excellent evening, especially inputs regarding the genetic testing is important. And as Dr. Anil puts it, and I put it very clearly, exercise, 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 lifestyle modification, or alternative, get admitted,
Hospitalization.
hospitalization. Thank you.
So from my side, there are two take-home messages. One is everybody, sir, don't fear genetic testing and their jargons. You know, they are very weird jargons to use. Please promote the testing, patronize us. And secondly, take-home message for me is that I have to read Amrit Khera's article from NEGM. Thank you, sir.
Thank you, thank you. And my is to consider in subsidized rate the genetic
Sir, definitely,
analysis
sir.
of the
Please, I
members
mean,
of
there's no question
CCDSI.
at all, sir. That's no question at all. We'll
And then
definitely.
now it's over to Dr. Lohani for the final round of many formalities, and I'll like Dr. Bitul sir to give any comment, and then Dr. Lohani will take up the rest of the proceedings.
Dr. Lohani, please proceed. We have already made so many comments.
Okay.
Please.
Okay, so thank you everybody for your participation, and thank you to both speakers and chairpersons. One thing all of you will agree that it was a unique and highly informative CME. Highly informative because of its academic content, and unique because perhaps it was a pan-India CME. One speaker is from South, chairperson is from North. One speaker is from West, chairperson is from East. And the final comment, concluding remarks came from none other than Dr. Vivani, whom I consider the Don Bradman of CCDSI. And last but not the least, we are lucky to have blessings from Dr. A.N. Rai, a person who needs no introduction in any gathering of physicians in this country. In fact, it was his vision that we are sitting here under the banner of CCDSI. With these few concluding remarks, I think Dr. Mrityunjay has not joined. So I will request Dr. Abhishek to propose vote of thanks, our Joint Secretary.
Thank you, sir. It's a really nice session, and we enjoyed it a lot. Probably I was not thinking that such information we will get through the CME. So I would like to thank our founder president, Professor A. sir, Dean Dr. Virmani sir, Chairman Scientific Committee, Professor Lohani sir, our speakers, Dr. Gurraj B. Sattur sir and Dr. Kamaljeet Chawla sir. Chawla sir, it was like आपका मंगल में शनि का प्रवेश हो रहा है, अब आगे जाके ऐसा कुछ होगा So it is very new thing.
Mm.
I was not expecting.
It's a genetic horoscope.
Yeah, it is a genetic horoscope, sir. So really, it would be a very great thing for humanity.
Thank you, sir.
I would like to thank all of the both of the speakers. High praise and thanks to Professor Jayant Panda sir, Dr. Vitul K. Gupta sir for conducting such talks with very interactive manner and putting their inputs and giving knowledge to all of us. I thank all the senior members present over here. I thank all the delegates and members of CCDSI for attending the CME. No doubt in our online library, this will become one of the pillars in coming days. Thank you. Thanks.
Thank you.
Thanks a lot to all of you.
Thank you.
Thank you. Thank you,
Thank
everyone.
you.
Thank
Long
you.
live
Bye-bye.
CCDSI.
Thank
Take
you.
care.
Thank you, sir.
Thanks, everybody.
Thank you, sir.
Thank you.
Thank you.